everybody. My name is Dr. Chris Clark, and I think everybody in here probably knows it, so I won't say that again. So, Sean Ray, who is a second-year Master's of Athletic Training student, is going to be talking about the cuboid syndrome and the different techniques that are used with that. So, Sean, I'm going to turn it over to you and let you go ahead.
Dr. Clark said, I'm Sean Ray. I'd like to start by thanking the GSU Student Symposium for allowing me to speak today. My topic I will be presenting is cuboid syndrome, manipulation techniques, and optimal patient outcomes. All right. So not everyone may know what cuboid syndrome is, let alone what the cuboid bone is. So it is the blue highlighted bone right there. It is one of the 7 bones of the foot and ankle, and one of the 5 bones of the midfoot. It is also located on the lateral aspect of the foot and helps with stability when standing and the movement of the toes. All right. So now into more about cuboid syndrome itself. Patterson and other authors define cuboid syndrome as a minor disruption or subluxation of the structural congruity of the calcaneal-cuboid portion of the mid-tarsal joint. Jennings and Davies and other authors agree that cuboid syndrome accounts for only 4% of all foot injuries in athletes, making it one of the most rare injuries in sports. The mechanism of injury that occurs most in athletes dealing with cuboid syndrome is a plantar flexion and inversion ankle sprain. Another common mechanism is an overuse syndrome, and this is typically seen in like ballet dancers that are standing on their toes for extended periods of time. Treatment for cuboid syndrome is initially handled conservatively. Healthcare professionals will help with pain management through NSAIDs and therapeutic modality, and stabilize and strengthen the foot and ankle with therapeutic exercise. The most important factor in treatment from research is the use of the cuboid manipulation techniques, and the techniques in question are the cuboid whip and cuboid squeeze techniques. The cuboid whip was first introduced by Newell and Whittle in 1981, and the patient will be lying prone with the knee slightly flexed. The clinician will be standing at the foot of the patient, and the clinician will cut the bottom of the foot with the fingers and places the thumbs over the plantar surface of the cuboid bone. With the ankle in 0 degrees dorsiflexion and all musculature relaxed, the clinician will whip the foot into inversion and plantar flexion while delivering a high velocity thrust directed dorsally at a 60-degree lateral angulation. And that's just a little preview of what it would look like. The cuboid squeeze is a modified version of the cuboid whip, and it was introduced by Marshall and Hamilton in 1992. And basically the clinician and the patient will be in the same positions, and it starts the same way, but the ankle is then placed into full plantar flexion, and then once the clinician feels the dorsal soft tissues relax, the cuboid is basically squeezed back into its anatomical position. Clinical scenarios involving the cuboid bone and cuboid syndrome are rare. This is because multiple ankle and foot injuries occur at a more consistent rate than cuboid syndrome, so the research for cuboid syndrome is not in high demand. With that being said, cuboid manipulation techniques need to be studied for efficacy and patient outcomes because it is typically the first treatment option. For my focus clinical question, it states, in athletes with cuboid syndrome, which manipulation technique, the cuboid whip or the cuboid squeeze, associates with more optimal patient outcomes? For my patient population, I have all athletes. My intervention is the cuboid whip, and my comparison is the cuboid squeeze. And then we're looking for which one produces more optimal patient outcomes. My search strategy included inclusion and exclusion criteria, search terms during my research, and the databases and total articles found. My inclusion criteria includes all sports, all study designs, and articles published in the last 4 years. And my exclusion criteria includes all non-peer-reviewed articles and articles that were published in languages other than English. Search terms I used during article treatment process include cuboid syndrome, sublux cuboid manipulation, and patient outcomes. And the databases that I used were Sport Discus and Google Scholar. And from that, I found 13 from Sport Discus and 250 articles from Google Scholar. Here's my evidence quality assessment. I chose three studies. These studies will get the message across about the importance of cuboid syndrome, but I used the Prisma scale, the JBI scale, and the M-STAR-2 scales, and these scales allow you to assess the quality of each article as well as their trustworthiness and value and reliability. So for my first article, Adams and Madden of 2009 published an article titled Cuboid Subluxation, a Case Study and Review of the Literature. The article combined a case study and review of the literature. It breaks the condition of cuboid syndrome down into an individual level as well as a more broad and holistic approach. The strengths of this article are the combination of a systematic review and a case study. The weaknesses include their exclusion criteria and the limitations. The results for this article show that to achieve a proper diagnosis, the clinician needs to retrieve a thorough history and examination of the injured patient. Typical treatment is conservative, consisting of manipulation, rest, physical therapy, and external cuboid support, resulting in successful patient outcomes. And surgery is typically the last resort treatment option. My next article is from Jennings and Davies, titled Treatment of Cuboid Syndrome Secondary to a Lateral Ankle Sprain, and it's a case series. The purpose of this article was to raise awareness of cuboid syndrome, possibly being the source of lateral foot and ankle pain following plantar flexion inversion ankle sprains. The strengths of this article are that it being a case study, really good patient outcomes, and the limitations that were within it. The weaknesses of this article are the number of patients in the case study series. There were only 7 participants in this one, and then the demographics for each. Results for this article show that severity and duration of symptoms will influence the number of manipulations needed to return to play. Manipulation followed by pain management is a viable standalone treatment option, and in acute cases of cuboid syndrome, patients may return to play the same day as manipulation. My final study was published by Patterson, and it is titled Cuboid Syndrome, a Review of the Literature. The purpose of this article was to inform all medical health care professionals about cuboid syndrome through the etiology, clinical diagnosis, commonly administered treatment techniques, and patient outcomes. The strengths of this article were the systematic review, patient outcomes, and the evaluation and treatment of that of cuboid syndrome. The weaknesses were the synthesis of the articles and exclusion criteria. Results for this article show that cuboid syndrome responds well to manipulation techniques. All patients reported a substantial relief of pain after the manipulation of the cuboid to its anatomical position, and including that research is needed in the specific areas of incidence examination and therapeutic intervention. For patient outcomes, they are typically successful following manipulation, and in some cases, as I said previously, they can return to play within 24 hours, if not immediately after the manipulation. According to Jennings and Davies, they suggest that after manipulation, patients responded with complete and long-term resolution after just 1 or 2 visits. Adams and Madden state that surgery for cuboid syndrome is rarely needed, but reports of outcomes are sparse. An acute diagnosis, an accurate diagnosis, and improved outcomes are dependent on appropriate awareness and understanding of this condition. For my clinical bottom line, cuboid syndrome, manipulation has been described as the treatment of choice for patients. The cuboid whip technique tends to work best for patients that sustain the plantar flexion inversion ankle sprain, whereas the cuboid squeeze typically works best for athletes dealing with overuse injuries, so like more or less the ballet and dancers that are standing on their toes for extended periods of time. Implications, for athletic training profession, new skills and knowledge to learn and practice and provide treatment for athletes. For the students, practical application, it will allow for practice of the newfound skills and knowledge, and for future research, that should include more prospective randomized control trials for efficacy of the manipulation techniques, and then a male versus female study to assess which gender cuboid syndrome affects more. In conclusion, cuboid syndrome is the misalignment of the cuboid bone secondary to ankle or foot trauma. The mechanism of injury is either a plantar flexion, inversion ankle sprain, or overuse trauma. Treatment options mostly include manipulation of the cuboid bone with either the cuboid whip or cuboid squeeze techniques. And the cuboid whip is best for the ankle sprains, and then the cuboid squeeze is best for the overuse injuries. These are my resources. And then I'd like to once again to thank the JSU Student Symposium for allowing me to speak here today. I'd also like to thank my professors and classmates for motivating me, and I would like to thank my family for the continuous support. And I'll do questions. Yeah, if there's any questions.
Well, I guess if there's no questions,
Gotcha.
we'll give you a round of applause again. And